Hello and welcome to our attendees here in the U.S. and around the world. Thank you for joining us for today's Nova Biomedical webinar, Evidence-Based Point-of-Care Testing in Pre-Hospital Care. Our speaker today is Anna Fuzieri, PhD, North Sector Point-of-Care Testing Medical Lead at Alberta Precision Laboratories, and Associate Clinical Professor of Laboratory Medicine at the University of Alberta in Edmonton, Alberta, Canada. Dr. Naveen Banga from Nova's Medical and Scientific Affairs Department will also join us to discuss the advantages of fast, accurate fingerstick methods and assays for point-of-care testing in the pre-hospital environment. My name is Rick Rollins, Senior Marketing Manager at Nova, and I'll be moderating today's event. You can post questions during the webinar using the Ask a Question tab on your webinar console. We'll address questions following the main presentations and follow up with a full list of questions and answers shortly after the webcast. As a reminder, you can register for future live events and explore our wide array of on-demand content with topics in clinical testing, cell culture, and veterinary diagnostic testing on the Nova website. Be sure to subscribe to receive notice of future Nova educational webinars. You'll also find more information about whole blood critical care testing products on the website. And now on to our main presentation. Dr. Anna Fuzieri obtained her PhD in biochemistry from the University of Wisconsin and subsequently completed a 2-year postdoc fellowship in clinical biochemistry at the Johns Hopkins University in Baltimore. She then accepted a position as clinical biochemist with Alberta Health Services in Edmonton, Alberta, Canada. Her initial responsibilities included overseeing clinical biochemistry testing in 11 rapid response laboratories. In 2017, she transitioned into point-of-care testing and became the medical lead for Edmonton, followed by all of northern Alberta. Dr. Fuzieri is currently an associate clinical professor of laboratory medicine at the University of Alberta, where she also co-directs the university's postdoc clinical biochemistry fellowship program. Dr. Fuzieri's current research interests lie in enabling high-quality, clinically relevant point-of-care testing in pre-hospital care and during critical care transport. Please welcome Dr. Fuzieri.
Hello, good day, everyone. Thank you, Rick, for that nice introduction. It is my pleasure to talk to all of you about evidence-based point-of-care testing in pre-hospital care. My name is Anna Fuzieri, as Rick mentioned. I am the North Sector Point-of-Care Testing Medical Lead for Alberta Precision Laboratories. And one of my passions is point-of-care testing in the pre-hospital setting. And I would like to thank Nova Biomedical for providing me the opportunity to talk about this topic, because it's very important, and I think it's also under-recognized. And a lot of times pre-hospital providers are kind of left on their own to figure out how to provide point-of-care testing in a high-quality, safe, efficient way. So hopefully with my presentation today, you will be able to go away, think about how you do your own point-of-care testing in the pre-hospital environment, and also how Nova can help you to improve the way that you perform it. So my presentation consists of 4 main parts. I'm going to introduce pre-hospital care in the Canadian province of Alberta. Then I'm going to switch over to talking about evidence-based guidelines, and specifically evidence-based guidelines for pre-hospital care. I'll follow that with some discussion about pre-hospital research. And finally, I will summarize my presentation, and I will give you some homework so that you don't feel like you just come and listen and then you go away. So I live in the Canadian province of Alberta. This is one of 10 provinces in the country. It's outlined in the red box here. It is 640 kilometers wide and 1,200 kilometers in length. The capital city is Edmonton. That's where I live. We have a population of about 4.5 million people, and the area of the province is approximately 662,000 square kilometers. Pre-hospital services are provided by over 500 ground ambulances. And you can see a picture on the left here. The large majority of these are operated by our provincial health authority, but there are also ambulances provided by contracted provider services. We also have 11 fixed-wing air ambulances that are operated by the provincial health authority, as well as 5 rotary wing air ambulances that are operated by a nonprofit organization called STARS. And we also have a stroke ambulance, which is Canada's only stroke ambulance. And this is a pilot project of the Provincial Health Authority, as well as the University of Alberta Hospital Foundation. And this is a really, really neat project. And so if you would like to read a little bit more about it, you can scan the barcode down at the bottom here. And I will bring you to a short article that was published last year in the Edmonton Journal about the stroke ambulance. So these various pre-hospital services use a number of different point-of-care testing systems. All of the services do point-of-care glucose testing. And just recently, we actually underwent an RFP. And as of this year, our ground ambulances and our fixed-wing air ambulances, and actually also the stroke ambulance, will be switching over to the Nova Stat Strip glucose meter. And then blood gases, hemoglobin, hematocrit, lactate, creatinine, and urea are performed by all of the air ambulances and then also in the stroke ambulance. And then due to the specialized nature of the stroke ambulance, it also will do PT-INR testing and platelet testing to help determine whether thrombolytic therapy is an appropriate treatment for the patients that it sees. So there are 2 different kinds of instructions for use that are used for the point-of-care testing in these pre-hospital services. The first one is a set of medical control protocols, including for critical care on board the air ambulances. And these are developed by engaging frontline paramedics, EMS physicians, and researchers. And in some instances, also the Alberta College of Paramedics or the Government of Alberta. And there's very strong emphasis on using high quality evidence to generate these medical control protocols whenever possible. And then the second set of instructions for use that are used are the point-of-care testing standard operating procedures. These are developed by Alberta Precision Laboratories, which is the public laboratory service in the province of Alberta, in collaboration with the clinical stakeholders. And here too, we aim to, whenever possible, use high quality evidence to develop the operating procedures. But as many of you might be aware, there isn't a whole lot of high quality evidence available for point-of-care testing in the pre-hospital environment. And so that's where kind of evidence-based guidelines come in. They're a good resource for using high quality evidence. And so I would like to take a look together with you about what kind of evidence-based guidelines are available for the pre-hospital setting. But before that, I would like to introduce you to this Prehospital Guidelines Consortium group, which I recently found out about, and which seems like a very cool and very exciting group to be aware of. So they're based out of the United States, and they represent American medical and EMS organizations that have an interest in pre-hospital evidence-based guidelines and their benefits to patient outcomes. And they have a couple of different objectives. So they want to promote these evidence-based guideline development research, also the guidelines themselves, and then any education related to the use of these evidence-based guidelines, promote the implementation of the guidelines, standardized evaluation methods for evidence-based guidelines, and also funding for evidence-based guideline-related projects. If you want to know more about this group, you can scan this barcode here on the right, and that will take you to their website. If you do have a few minutes, I strongly encourage you to go and check out their website. They have a lot of really useful resources, some of which I will talk about in the upcoming slides. So the reason that I wanted to introduce them is because in 2021, they published a systematic review of published guidelines of pre-hospital care. And what they did was they did a search of 5 different databases mentioned here. So Embase, Medline, PubMed, TRIP, and guidelines.gov. They looked for English language articles or guidelines that were published prior to September 2018 on pre-hospital care. And then they took the guidelines that they found and they appraised them using 2 different tools. So the Agree-To tool is a tool that became available in 2010 and is widely used worldwide to assess the quality and reporting of practice guidelines. And then the second tool that they used were criteria that were established by the United States Department of Health and Human Services based on recommendations from the National Academy of Medicine in 2011. So they found a total of 71 guidelines that they appraised, and 68 of these guidelines were on 1 or more clinical topics. The most common clinical topics were injury, time or life critical conditions, and medical emergencies. And then out of the 71 guidelines, 11 guidelines were on 1 or more non-clinical topics, with the most common ones being on special operations, such as wilderness EMS systems, medical oversight, such as EMS personal education, EMS provider health and wellness, and quality improvement, for example, data collection, data management, and data analysis. So I will just briefly show you the findings and the conclusions of the authors. If you're interested in actually reading the full review, one of my previous slides had a barcode and you can just scan that and that will take you to the review. It's actually available free at the publisher's website. So out of the 71 guidelines that they appraised, they found that the guidelines had a range of average Agree-To domain scores from 19% to 89%. So the lower the score, basically the poorer the quality of the guideline. So 89 is really good, 19% is not very good. There were only 9 guidelines that had an average Agree-To domain score of more than 75%. So really only 9 guidelines that they considered very high quality. And then with respect to the National Academy of Medicine criteria that they used, there were 27 out of 71 guidelines that met all the NAM criteria. So that's, again, not too bad, but it's not great either. Most of the guidelines that they assessed included the elements of benefit and harm assessment and a summary of the evidence synthesis. But many guidelines were missing the following elements listed here. So a description of the search strategy, explicit evidence synthesis, study selection, performance, or elements of systematic literature review. So based on these findings, the authors made several conclusions. So the first one was that there is definitely room for improvement across most of the guidelines available for pre-hospital systems. And they based that both on this big range of domain scores that they saw, and also that the majority of the guidelines did not have actually a very high score. The second conclusion that they drew from kind of the NAM assessments was that there are important gaps in reporting that exist within the clinical guidelines for pre-hospital medicine. And the third conclusion that they made was that the funding available to develop guidelines and the methodology used to develop guidelines are 2 very essential pieces for high quality guideline development. And something that kind of enforced their conclusion was that the two highest scoring guidelines both had very strong funding and also very good methodology. And I'll talk about one of the high scoring guidelines in my next couple of slides. Now, one of the really neat things about the systematic review and the consortium and their website is that if you go to their website, they actually have all of the guidelines that they included in the systematic review. So if you scan the barcode in one of my previous slides that takes you to their website, you can then click on one of the links that they have for evidence-based guidelines, and that will take you to a website that looks like this. And then you can search either based on a word or a topic that you want, or you can just peruse based on titles of guidelines or other categories. So I put in stroke here, and then that brought up all of the guidelines that are related to stroke. And you can see the authors, the title of the guideline, the category for the guideline. You can see whether the NAM criteria have been met by this guideline, what the average agreed to domain score was. And then there are also links here. And if you click on these links, they take you to the publisher's website where the guideline is available. And in many instances, I didn't check all of them, but I did check a few. If you click on this link and go to the publisher's website, the guideline is there and can be downloaded free of charge. So I just want to show you here, this second guideline here. This was the highest scoring guideline. So it's about stroke and best practices for stroke. So if you click on this link here, then that takes you to the journal that published the guideline. And then you can click on the PDF here and actually download the guideline. So I want to just show you two screenshots from the guideline and show you part of the reason why it ranked so high. So this screenshot is part of the method section where they describe their methodology. And you can see here that they used an interdisciplinary group of experts to participate in the reviewing, drafting, and revising of all the recommendation statements. They did a comprehensive systematic literature search to identify relevant evidence. They included systematic reviews, meta-analyses, randomized controlled trials, and observational studies whenever available. And then they have a very nice description of how they assigned recommendations based on available levels of evidence. And one of the things, too, that the authors of the systematic literature review noted was that this guideline was entirely funded by the Canadian Heart and Stroke Foundation. And it's a well-funded, long-standing and national organization that has the resources to gather and support a large group of interdisciplinary experts. And so that's where the funding piece comes in, and the funding being really important in being able to develop high-quality evidence-based guidelines. So then if we go to the next screenshot, I just pulled out an example where they have a recommendation related to point-of-care testing. So this is paramedic on-scene management, as you can see here, for patients who potentially may be having a stroke or have had a stroke. And you can see recommendation 4 here. Initial assessment provided by the paramedics on scene should include a capillary blood glucose measurement. And they say that there's evidence level B for this, which means that there's single randomized controlled trials, quasi-experimental design with large samples and power. So it's a pretty good evidence level. And so you can do this with other guidelines on this website that are part of the systematic review. Now, hot off the press, something that's really exciting is that the same group actually just published an update. So they did another systematic review. This time they looked at articles from January 2018 to April 2021. And they published that as a 2022 systematic review. The articles that are mentioned or the guidelines that are mentioned in this review are not yet up on the consortium's website. So if you're interested in looking at them, then you'll have to download this article. And again, you can scan in this barcode and it will take you to the publisher's website. It is free charge. So you can download it and then you can just look at the references at the back and kind of find the relevant guidelines yourself. Now, evidence-based guidelines are great, but of course, you need evidence to generate the guidelines. And so that's where pre-hospital research comes in. Pre-hospital research is really important to generating the evidence to then create the evidence-based guidelines that we can use to guide how we perform point-of-care testing in a pre-hospital setting and how we perform pre-hospital care. So here I just wanted to show you one example of EMS research and a Canadian a country highlighting the need for pre-hospital research and its importance for developing evidence-based pre-hospital care. So the Canadian National EMS Research Agenda came out in 2013, and it was developed by the EMS Chiefs of Canada in partnership with the Paramedic Association of Canada. And really, this quote here explains why they developed it. Research is essential for the development of evidence-based emergency medical services systems of care. When resources are scarce and gaps in evidence large, a national agenda may inform the growth of EMS research. So if you look at the evidence-based guidelines that I mentioned before, you will see that there's a lot that is still missing. And particularly when it comes to point-of-care testing, and not just the application of it and how it's beneficial in the pre-hospital setting, but also what the quality assurance should be that's in place around it. There is much that still needs to be identified, to be characterized, and there aren't resources to do everything. So having a national EMS research agenda can partly help with identifying where those biggest gaps are, and then finding funding to focus on those gaps first. Now, in the next couple of slides, I would like to show you two examples of pre-hospital research focusing on point-of-care testing and the kind of evidence it can generate and help us to move forward in developing evidence-based guidelines. So the first article that I will talk about is more focused on the lab aspect of point-of-care testing in a pre-hospital environment. And then the second article will be more focused on the clinical application of point-of-care testing. So there is growing interest in pre-hospital lactate point-of-care testing and the impact that it could potentially have on on-scene patient care, on making decisions about appropriate transport and transfer of patients to hospitals, and also about optimizing both pre-hospital resources and hospital resources. So this slide just shows you three examples of recent publications on pre-hospital lactate and its potential uses. So first article looked at a modified SOFA score, and it found that if you use lactate instead of platelets and bilirubin, you can predict with good accuracy the risk of short-term mortality in patients with acute disease who are treated by EMS. The second article looked at pre-hospital lactate and found that it can be used to predict the need for in-hospital blood products in patients suspected of having major traumatic hemorrhage, which would then impact kind of the communication between the pre-hospital provider on scene and the receiving hospital. If you alert them early that you have a patient coming that might need blood products, the hospital can prepare them, have them ready right away when the patient is coming. And then the third article looked at lactate, pH, and PCO2 and found that you can use the three together in a pre-hospital lactic acidosis score to predict 2-day mortality and ICU admission. Now, one of the things that was common amongst these three studies is that they all used venous blood samples for the testing. And venous blood sample draws, while they're, I guess, not one of the hardest blood samples to obtain, but still they require some expertise in venipuncture or putting in IV lines. They're not an extremely easy sample to obtain, especially when you're in the pre-hospital setting and there might be other things going on around you that are chaotic, also time sensitive. So there are a couple of questions here that might be of relevance. One is could capillary samples be used in place of venous samples to eliminate the need for venipuncture? Could you obtain the same information from capillary samples? Another question is, could the study conclusions be transferable to situations where you have a patient who has an art line in that's being transferred, for example, during critical care or ambulance transfer? Can you just draw arterial line samples since the patient already has the line instead of having to either poke them for a venipuncture or put in a venous line as well? So basically, our samples, our capillary samples, venous samples, arterial samples, giving you lactate results that are pretty much the same and interchangeable. Can you take the conclusions from a study like the one here on venous sample and just assume that the same will be true if you do a capillary sample or an arterial sample? So the study that I want to talk about in a bit more detail tries to address that question a little bit. And again, if you're interested in the study in full detail, you can scan the barcode here to take you to the article. Here, I will only describe some of the details and the most important results and findings. So this was a prospective convenience study that was carried out in Denmark using a mobile emergency care unit in a mixed rural-urban area. And this unit was staffed by an anesthesiologist and an emergency medical technician. And since 2013, it has been equipped with an onboard blood gas analyzer. And so whenever the anesthesiologist feels that there's a need for an arterial blood gas, then that sample is drawn and analyzed on board this blood gas analyzer. Now, for the study, what they did was they took a Nova Strip Express lactate meter and they placed it into the unit's driver compartment. And then they looked at whether capillary samples and venous samples tested on the lactate meter could provide equivalent information to arterial samples tested on the blood gas analyzer. Patients who were eligible for enrollment in the study were ones who required an arterial blood gas sample for routine care by the unit. And based on these eligibility criteria, they were able to enroll 111 patients between May 30th, 2019 and January 21st of 2020. So here, this is a brief description of kind of what kind of samples they used. So they used arterial, venous, and capillary samples for the study. So from each patient, they obtained 3 samples. An arterial sample was obtained into a blood gas syringe, and that was tested on board both the onboard blood gas analyzer and the Nova Strip Express lactate meter. And they used the blood gas analyzer result as their reference result. And that's the one that they used for the clinical decision making, because that was kind of the standard of practice for them. But at the same time, when they drew the arterial sample, they also established intravenous access with the patient. And then they drew a venous sample into a vacutainer. And they performed a capillary fingerstick puncture and used a second drop of blood to test on the stat strip express lactate meter as well. So they ended up testing a total of 334 samples on the stat strip express. Of these, 109 were arterial, 92 were venous, and 108 were capillary. And they only had 2 errors from the 334 sample tests in total. And one of these errors resolved upon repeat of the test. So that's already very, very good result. And then on the right here, you can see a graph, Bland-Altman plot, that shows the difference in lactate measurements between the stat strip express lactate meter and the onboard blood gas analyzer. And what they found was that there was quite good correlation, really good correlation between the 2 different point-of-care devices at lactate values approximately less than 6 millimoles per liter. And then as the lactate increased, the difference between the 2 devices increased as well. Now, this is not unusual. Lactate is not a standardized test across the world because of differences in calibrators and traceability. So it's not unusual for there to be differences between 2 devices or 2 analyzers from different companies. That's normal. And so the difference seen here is expected. The authors concluded that the difference that they saw below 6 millimoles per liter was actually completely acceptable from the perspective of patient care, because really in situations like this, what clinicians are looking at is whether the lactate is around 2 millimoles per liter or less or higher than that. That's where the main clinical decision point lies, around 2. And that's where a lot of decisions are made. If your lactate is greater than 6, then the accuracy is not as important, because whether it's a 6 or a 7 or an 8, it's very elevated, and the clinical management is not going to differ a whole lot. And so they found that the agreement between the 2 methods around 2 and below 6 was acceptable for clinical care. And then other conclusions that they made from their results, which I won't be able to show you all here. But again, if you're interested, feel free to just download the paper yourself and read all of it. So they found that venous samples are a good alternative to arterial samples for lactate testing in the pre-hospital setting. There's a low bias between the 2 types of samples and the results that they give. And there's a low risk of misclassification in terms of whether the lactate is elevated or not. They also found that capillary samples were inferior to venous samples when estimating arterial lactate. And you can see the little chart here on the right is what they used to make this conclusion. So this is the stat strip express that they used to test capillary blood samples. And this was the onboard blood gas analyzer that they used to test arterial samples. So in about 73% of the time, when both of the devices gave a result less than 2 for the same sample, in about 73% of the time, for the same sample, both devices would categorize it as between 2 and 3.9. And then about 90% of the time for samples, if a sample gave a result greater than or equal to 4 on the stat strip, it would also give a result greater than or equal to 4 on the onboard blood gas analyzer. But in about 25% of the time, there was a discrepancy between the 2 devices in terms of characterizing the sample as having a kind of normal lactate versus an elevated lactate. And then in about 9.1% of the time, there was, again, also a discrepancy between characterizing a sample as having a very high lactate or having either an intermediate or a low lactate. So based on this, they concluded that capillary samples really are not a good choice if you want to assess the patient's true lactate status. The final conclusion that they made was that, again, because there tends to be variability in lactate standardization and results from one device to another device, when the devices are from different manufacturers, it's important to validate the findings that they had on their stat strip and their onboard blood gas analyzer. It's important to validate a similar setup locally using the local point-of-care device and reference chemistry analyzer. So if you're in a different part of the world and you're using also a Nova stat strip lactate meter, or you're interested in using that, you should find out what your either laboratory's reference analyzer is, or if there's another point-of-care analyzer that you tend to use as your reference for lactate testing. Then you need to determine locally how well your stat strip express lactate meter agrees with whatever you consider right now to be your reference. So that's a more kind of lab-oriented study that focuses on point-of-care testing in a pre-hospital setting. The next couple of minutes, I would like to show you a study that is more clinically focused, looking at clinical applications of point-of-care tests that historically have been used in the hospital, but not in the pre-hospital setting. And I'm particularly excited about this one because this is a study that is still ongoing and the results are not yet available. And to me, it's something really, really different from what I've seen before. So, official title of this study is Use of Capillary Blood Ketone Meters to Improve Ambulance Service Care of Hyperglycemic Patients, a Feasibility Study. And the sponsor is East of England Ambulance Service NHS Trust in the UK. And they're basically trying to answer whether ambulance staff can reliably and safely identify patients at high risk of DKA in the field using blood ketone meters and start fluid therapy before hospital arrival. And the reason that this question is important is because diabetic ketoacidosis can be a life-threatening condition that requires immediate treatment. If you're in the hospital, one of the things that will be started right away upon DKA diagnosis is IV fluid therapy. But in the pre-hospital setting, when you're on scene, most ambulances do not have blood ketone meters available. And so ambulance staff have to rely on non-specific clinical signs and symptoms to decide on a patient care strategy. And so doing a study like this could really help to revolutionize the way that DKA is treated and potentially start patient treatment, appropriate patient treatment much earlier. And again, here on the left, if you're interested in learning more about the East of England Ambulance Service NHS Trust and this study, this barcode will take you to their website. And then they have also registered this trial at this website. So you can go there to find out more details as well if you're interested after hearing what I present here. Based on the information available, the study started in October 25th of 2021 and was estimated to complete in November 30th of last year. It's an open label stepped wedge control study, and it consists of two phases. There's a control period that's 4 months in length. The target was to enroll 400 patients with the inclusion criteria listed here. So equal to or greater than 18 years of age, attended to by the study clinician. There's informed or proxy consent, and the glucose is greater than 11 millimoles per liter, or it's an individual who's unwell and has known diabetes. And in this control period, these individuals would be provided the usual ambulance care, which, if necessary, would include transfer to a hospital. And then in the intervention period that follows, that is also 4 months and target of 400 enrolled patients. Same inclusion criteria, but the care provided will differ. So the care includes usual ambulance care and also a capillary blood ketone test right on scene. And if the ketone is elevated and there's a high risk of DKA based on the other parts of the assessment, then IV fluid therapy would be started for the patient on scene. Now, I did try to find out what the study team considered an elevated ketone. That was not listed on the sites, so I cannot tell you that. But hopefully there will be a publication soon, and then we will know. And after the study team also planned to interview 20 ambulance and hospital clinicians about their patient care experiences and ambulance ketone meter use. And so their primary outcome measures included the incidence of hyperglycemia with a glucose greater than 11 millimoles per liter, the incidence of DKA with that being considered ketones equal to or greater than 3 millimoles per liter, together with the hyperglycemia, completeness of data capture by the study clinicians, and incidence of adverse events. And the results of the feasibility study will be used to decide if a full-scale clinical trial is appropriate to plan. And in order for a full-scale clinical trial to go ahead, there are 2 progression criteria as absolute requirements. One is that the completeness of data capture by the study clinicians needs to be at least done for 70% of participants, and the adverse event rate needs to be less than 1% of participants. And as I mentioned, the results are not yet published, so I'm eagerly awaiting them. Again, I think for us here in Alberta, the results of this could really be something that eventually really changes clinical practice when it comes to treating DKA. So stay tuned for that and keep an eye out for that. All right, so this is my second last slide. I would just like to summarize my presentation. So I hope that you were able to learn and understand from this presentation that point-of-care testing is an important component of pre-hospital patient care, that pre-hospital evidence-based guidelines should inform point-of-care testing practices whenever possible, that pre-hospital research is essential for evidence-based guideline development, and that point-of-care testing is a growing focus of pre-hospital research. And so that's kind of my presentation, and now it's your turn to do some homework. So I would like you to ponder the following questions after this presentation is done and you have some downtime. Does your organization use evidence-based guidelines to inform its point-of-care testing practices? And I want you to think about this both in terms of the clinical application, so where is point-of-care testing used in the pre-hospital setting, and what is the evidence for using it in those applications? But I also want you to think about it with respect to the quality assurance piece. So what is the evidence available that tells me or tells you whether QC should be done, whether proficiency testing should be done, whether patient comparisons with the laboratory should be done? Am I just doing it randomly? Am I doing any of it at all? Should I be doing some of it? If yes, what should that be? I would like you to think about whether there are any pre-hospital point-of-care testing that is recommended by an evidence-based guideline that your organization doesn't currently perform but should consider doing so. And if you go to that 2021 systematic review and now the 2022 systematic review done by the consortium, those will be great places to start looking at this. So you can pull up guidelines that are relevant to the care that you provide to your patients, and you can look whether there are any recommendations in those guidelines for point-of-care testing. And then finally, what research studies can your organization perform to contribute to the growing evidence base for pre-hospital point-of-care testing? And again, the guidelines are a good starting point to see what there is. You can also look in the literature at actual individual research studies. And then my impression over the last couple of years is that Nova Biomedical is also a really great resource. If you look in the literature, a lot of the pre-hospital point-of-care testing focused studies have been either sponsored by Nova Biomedical or use their products. I think they're very invested in the pre-hospital space, much more so than many other manufacturers that create point-of-care testing devices, that maybe market the devices to the pre-hospital space, but aren't involved in generating the evidence base for their use. So I think talking with colleagues at Nova, if you have any, there is also a good starting point for thinking about research studies or even planning research studies and seeing what products you might want to use in the studies. So that is the end of my presentation. Thank you for listening. And now back to you, Rick.
Thank you, Dr. Fuzieri. Excellent presentation. I encourage our attendees to seriously consider the questions posed in your homework assignment and to reach out to their local Nova Biomedical representative to discuss point-of-care tests that may be appropriate for their institutions. Our next presenter, Dr. Naveen Banga, will now speak on specific point-of-care tests for use in the pre-hospital environment. Naveen?
Great. Thank you, Rick, and thank you, Dr. Fuzieri, for that very interesting presentation. Today, I wanted to follow up that presentation with a few notes about lactate testing and ketone testing in pre-hospital setting. So let's start with why lactate is increased during trauma or sepsis situations. So during trauma or sepsis, you have hypoperfusion, so blood not circulating very well to the cells of the body. And that leads to anaerobic metabolism. And anaerobic metabolism results in the production of lactate rather than large amounts of ATP, which occurs in aerobic metabolism. And adding to this is epinephrine and other stress response hormones, which lead to a hypermetabolic state. And that, in the presence of low oxygen due to the hypoperfusion, again, exacerbates the lactate production. So lactate actually increases within 30 minutes of injury. And you can measure this with a meter and a strip, and that adds prognostic value for the patient, and by quantifying the lactate level. And not only the absolute levels, but the serial trending of lactate can help show clearance and give predictive value. And I'll show you that in the next couple of slides. So this is a review study of over 2,000 trauma patients, and they're looking at their pre-hospital measurement of lactate. Depending on the study, the lactate cutoff was either somewhere between 2 or 3.5 millimolar, as where they used as the elevated levels of lactate. And when those levels were elevated by that cutoff, that predicted critical illness or mortality. And it was better, lactate measurement was better than systolic blood pressure, mean arterial pressure, or heart rate, for example. And now looking at when they reviewed studies looking at serial lactate measurements, where they had more than 2 measurements, when they looked at the pre-hospital measurement, so that's the T1 or the time 1 measurement, and at emergency department arrival, that's time 2, the mean difference between those 2 measurements was around 27 minutes. And if the measurements at those 2 times were both greater than 3.5 millimoles per liter, then the mortality was 49%. However, if there was a decreasing trend, meaning if time 1, so the pre-hospital measurement was greater than 3.5, but then at time t it reduced to below 3.5, the mortality decreased substantially down to 14%. So you can see that having maintained high levels of lactate is associated with a higher risk of mortality, whereas if it's decreasing from above the cutoff to below that threshold, your mortality drops to 14%. Now, looking at another study, a multi-center study from Spain, over 3,000 patients, where they were looking at this national early warning score that is used for looking at the assessing health of usually trauma patients and in severe conditions. The NEWS score includes pulse, blood pressure, respiratory rate, temperature, oxygen saturation, and level of consciousness, and patients can be categorized as low, medium, or high. And that's a well-established risk score used in several countries in the European Union. In this study, they looked at adding lactate to the NEWS2 score, and what you can see on the right side is how well lactate adds predictive value to the risk score. So if you look on the left side of the bar, you've got the left side of the graph, you've got the patients in low-risk NEWS, and those that are have low lactate levels below 4 millimoles per liter have a 0% risk of mortality. However, if they have an elevated lactate, even though they have the low risk score for the NEWS, it would be increased to 1.5%. So a modest difference, but where you really see the value of lactate is those patients who have high risk NEWS. If they have low lactate, their risk of mortality is 2.5%. Whereas if they have high lactate in the orange bar, their risk jumps to 20%. So they've added lactate measurement to their NEWS score in these warning scores for predicting patient mortality. And so this is just a diagram of the StatStrip lactate device. It's portable, handheld meter that can give results in 13 seconds with really a very small amount of blood, 0.6 microliters. And that's how it can be measured in a very rapid and efficient way. I want to move on to diabetic ketoacidosis. As you heard Dr. Fuzieri talk a little bit about this in a forthcoming study. So patients can present with a variety of symptoms, including frequent urination, but if it gets more severe, it's nausea, vomiting, abdominal pain, confusion. So quite severe symptoms that often end up with these patients coming to the emergency room. And typically it's diagnosed with a high plasma glucose level, greater than 14 millimolar per liter, low pH, that's the acid part, the acidosis, and then serum and or urine ketones, beta-hydroxybutyrate being one of those ketones and being the most predominant in the serum, serum bicarbonate less than 15, and GAP greater than 12. So that's the general features of diabetic ketoacidosis. And I just wanted to go over a bit of the metabolism behind that in a patient with diabetes, for example. What you can see on the far left here is blood glucose levels that are increased with meals, for example. When that happens, you get insulin production from the pancreas, but I'm showing a case of type 1 diabetes where the CD8 positive T cells are killing off those pancreatic beta cells and leading to decreased insulin. So you don't get the glucose uptake, you don't get glycogenesis or gluconeogenesis is going down. But bottom line is the blood glucose levels are elevated. They maintain elevation because insulin is not being produced to drive that blood glucose into cells. So you've got low insulin in these patients with diabetes, high blood glucose, and the cells are absolutely starved of glucose, even though there's lots of glucose in the blood. They're basically bathed in glucose, but it's not getting into the cell. So the cell internally is starved with blood, so the cells have to find an alternative source. And that alternative energy source is actually using fatty acid breakdown. What you can see here is fats will break down fats from fatty into fatty acids and glycerol. The glycerol is used to convert to glucose. And the fatty acids result in ketone generation in the liver, and those ketones then are released into the blood. So with this high blood glucose, in the case of diabetic ketoacidosis, you've got high blood glucose, the blood becomes acidic, so your pH drops, and that's because of those ketone bodies. The ketone bodies that are produced are things like acetic acid, beta-hydroxybutyrate, and acetone. And so that defines diabetic ketoacidosis. The glucose is the diabetes part, the acidosis is the low pH here, and the ketones are what's driving it. And it's really the beta-hydroxybutyrate that's produced at a 3-to-1 ratio. So it's the most predominant ketone that's produced in these patients, much higher levels than acetoacetic acid, for example. And so what happens when that occurs is these ketone bodies that go into the bloodstream are then metabolized into acetoacetate. And so that metabolism occurs in muscle cells, for example. And so when you look at production and you look at blood measurements of beta-hydroxybutyrate, you can see it will increase over some time period as a patient is getting more sick. And as there's treatment, it'll decrease. So the red line here is showing blood levels of beta-hydroxybutyrate. And the acetoacetate, though, is a delayed function and a delayed appearance because it's being metabolized by muscle cells, and that's what's producing it for the blood. And so when you look at the urine acetoacetate, especially, it has to be metabolized and then excreted. So it takes much longer to show up here in the blue line, and then it starts to decrease much later. So in the end, what you can see here is that when you have resolution of ketoacidosis, for example, here you have stopped production of ketones. Instead of ketones being increased in the serum, it's decreased, but the acetoacetate may continue to increase. And so what you can see is this window is during the resolution phase, the blood beta-hydroxybutyrate will be decreasing. So that's resolution of ketoacidosis, yet urine acetoacetate is increasing still, because it's still being metabolized and being excreted. It's a delayed function, as I mentioned. So really, that's a point to note that blood beta-hydroxybutyrate is a better measure, more accurate representation of what's going on currently in the patient. So when we look at the burden of diabetic ketoacidosis in the USA and healthcare utilization, it's really a staggering amount. So there's 25 to 30% of type 1 diabetes present this way. Mostly it's those presentations of younger patients. In type 2 diabetes, it's also 4 to 29% can present this way with their initial incidence of diabetes. And so this study looked at a 10-year analysis from 2003 to 2014 and looked at the sample database, over 1.7 million primary admissions and 7,000 deaths, and how much this was costing the healthcare system. And what you can see is from 2003 to 2014, the number of patients discharged with the diagnosis of diabetic ketoacidosis is somewhere over 125,000 or so, upwards to 175 in 2014. The mean cost per patient has gone up from $18,000 or so to about $27,000. And the national bill this is the number that's quite staggering, a little over $2 billion to $5 billion annually. And the mortality rate is going down from 0.5% to 0.3%, and that's because it's being identified better, more efficiently. So when we look at patients that come into the emergency room, this is a study looking at 111 patients coming into the emergency room over a 3-month period, and they were triaging these patients that they would measure blood glucose if they had a history of diabetes, they had current or past use of hypoglycemic agents and or insulin, and they had presenting symptoms such as hyperuria or polydipsia, so excessive thirst or excessive urination. And when they did this, they noted that that when they used beta-hydroxybutyrate as a measure to help with the diagnosis of diabetic ketoacidosis, if they used a cutoff of 3.5 millimolar, their diagnostic sensitivity and specificity, predictive value and negative predictive value were all 100%. So quite a remarkable addition to have this additional test of ketones of the blood beta-hydroxybutyrate to help in the diagnosis of diabetic ketoacidosis. And this is also supported by another retrospective study of 122 ER patients, where the authors suggest that DKA was more accurately predicted by quantitative determination of 3-hydroxybutyrate or beta-hydroxybutyrate than by urine dipstick analysis of acetoacetate. So it's an important measure. It's looking at that blood measure over the urine. When we look at another study at the sensitivity and specificity, looking at 479 patients that are known or newly diagnosed diabetes, non-trauma, for example, and their fingerstick glucose was greater than 200. If they had a positive capillary beta-hydroxybutyrate, then they were included in the study as well. So of these 139 patients that were included, because they had a greater than glucose greater than 200 mg per deciliter, and they had some detectable level of beta-hydroxybutyrate, then the full battery of tests were done on them. So capillary beta-hydroxybutyrate, venous blood glucose, arterial blood gas, so looking for the acidosis, and then urine dipstick. And you can see on the right measures here, when you're looking at diabetic ketoacidosis, either by, here's the urine and here's the capillary beta-hydroxybutyrate. You can see that having capillary beta-hydroxybutyrate has a higher sensitivity, 72%, compared to measuring it by urine, for example, 66%. And in the orange bars, comparing the specificity, it's also higher, 82 versus 78. So capillary beta-hydroxybutyrate is really additive and helpful in the sensitivity and specificity of measuring for detecting diabetic ketoacidosis. So overall, this point-of-care blood ketone testing can help lead to better patient outcomes. You've got, even in the pediatric population, you've got a 5.8 hour faster decrease in ketone levels compared to urine by using beta-hydroxybutyrate. The resolved ketosis occurs 4.6 hours earlier than urine, and so patients ended up leaving the ICU earlier. And that's a return on investment in terms of the cost savings for the lab and clinical assessment of 29.8% and 70.2%. Also, in looking at an endpoint for IV insulin therapy, that was decreased from 17 hours to 28 hours versus 28 hours for patients that were monitored by urine ketone testing. So when patients were monitored by blood beta-hydroxybutyrate, they reached the endpoint first. They could stop their insulin therapy at 17 hours compared to 28 hours for patients that were monitored for urine ketone testing. So measuring blood ketones and blood glucose, for that matter, can be done on one handheld portable meter. And again, like lactate, the results are fast in 10 seconds. And like lactate, they also use a very small sample of blood, 1.2 microliters. And in terms of measuring beta-hydroxybutyrate with handheld meters, there's issues of potential interference. And looking here at the stat strips, meters on the left graph here, you can see that they match up perfectly, really on a perfect fit on the slope of 1 here, with stat strips 1 or 2 different lots, so slope of 0.99 and 0.97. Compared to some other meters where you can see some bias, for example. And in terms of interference, when you look at hematocrit interference, so this is looking at blood ketone measures over different levels of hematocrit, from 25 to 65%, for example. And you want these lines to be horizontal. You don't want the level of hematocrit to be influencing the actual measure of ketone shown here on the y-axis. So you can see stat strip 1 and 2 different lots of stat strips are very stable across 3 different levels of ketones here. And as they are in the case of glucose, the black and the blue lines, very stable across. Whereas in red are other meters where ketone measurements, you can see drop dramatically over as the hematocrit increases at 3 different levels of ketones. So stat strip is really interference-free there, making it more accurate, more reliable meter. So just to summarize then, lactate is produced in trauma settings because of the anaerobic respiration. Elevated levels of lactate are predictive, but so are those non-decreasing trends of lactate. So if it's stable level or increasing, that's predictive of mortality. And then stat strip lactate can measure blood lactate levels, as I mentioned, with a very small quantity of blood. Similarly with glucose and ketones, an important measure in measuring and detecting diabetic ketoacidosis, which is a huge burden to the healthcare system. Several guidelines recommend blood beta-hydroxybutyrate over the urine measures, and blood beta-hydroxybutyrate measurements can lead to better patient outcomes. Earlier release from ICU, earlier stopping of IV therapy for insulin, for example, and ketone measurement by stat strip is correlates well with the reference methods and is shows minimal interference. So with that, I'll pass it back to Rick for any further questions.
Thank you, Naveen. Now, before we begin the question and answer session, please remember that you can submit questions for Dr. Fuzieri and Dr. Banga using the Q&A tab on your screen. Now let's go back to Naveen for the question and answer session.
Thanks, Rick. And our first question, Dr. Fuzieri, is about evidence-based guidelines. And the question is, given that you talked about evidence-based guidelines, how has evidence-based guidelines changed practice in your setting, for example, where evidence-based guidelines has changed things to include new things or to take away things that might be unnecessary?
I guess there are two components to it, and I can speak to one component better than the other. There is the clinical component to it with respect to, do we need a point of care test? Is there an actual clinical application versus not really? And what's the evidence for the clinical application? And then there's also the other aspect of evidence-based guidelines available to develop the quality assurance part for the point of care testing. So let me answer the second part, because that's easier for me, which is the quality assurance part. So my impression is that there actually is very little evidence for the quality assurance part, especially in the pre-hospital setting. So historically, what we have done, and it's still being done now, and I think it's a very wide practice, is that whatever quality assurance evidence there is based on past research that was done in hospitals, we just take that, at least in Alberta, but I think my impression is it's more widely done. We just take that and we just adopt it for the pre-hospital system as well. So we will validate reagents, but we'll validate them in the laboratory where the environment is very well controlled. We don't think about validating them in the environments that they may get exposed to in the pre-hospital setting. I think that people are starting to recognize now that that's not really the best thing to do. And so I think there's starting to be a little bit more research into how does the pre-hospital environment differ and how does that impact point of care testing reagents and devices, and generating that evidence so that we can develop guidelines around it. But I don't think there's anything really there yet. I guess one thing I do want to mention is that I know that CLSI is working, for example, on a guideline that's for emergencies and disasters, which will really be, and point of care testing in that setting, which will really be kind of the first of its kind of guideline for point of care testing kind of QA in that setting. So at least it's starting to be recognized and there's a need for it. From the clinical perspective, I think, I don't know, in Alberta, I don't yet have a concrete example to tell you of where the evidence-based guideline made a change. But what has happened and what is happening now is that with, again, increased awareness that we can't just translate things from the ER into the field, when pre-hospital providers are starting to come to the lab for point of care testing support or requests for point of care testing, we will start looking at what guidelines are there to just have those conversations about whether that's an appropriate application or not. Whereas in the past, I don't think those conversations ever occurred. So people just translated whatever was available from the hospital into the pre-hospital setting. Lab often was not involved at all in those discussions. And they just assumed that it will work. And so I guess, yeah. I don't know if that answers your question.
Yes. So it sounds like it's still early days yet, and it's about standardizing methodologies so that we can get to the guidelines, get to a standardized approach.
Well, yeah, I mean, that's work in progress as well, because as we saw from the systematic literature review, the guideline review, up to 2018, the first systematic review, what they found was this really big range of agreed to scores. What I didn't mention was in the more recently published review that was published last year, they actually found that the number of guidelines that had higher agreed to scores actually increased. And also the range, I think, narrowed as well. So, and they attribute that to increased recognition that there needs to be better reporting of how the guidelines were generated. So they have seen improvement in even just generating the guidelines.
Okay, the next question is about ketoacidosis, and it's about whether the ketone testing is better in urine or in serum. And so I guess the question is whether you can comment on the pros and cons of urine versus blood testing for ketones.
Sure. Yeah, so urine ketone testing tends to kind of look for, there are a couple of different ketones that appear when you have diabetic ketoacidosis. The predominant one in blood is beta-hydroxybutyrate. And so that's what most of the blood ketone meters will test for. The urine ketone strip will test for kind of a wider range of ketones. And so it's not that good at picking up the one that's predominant in the blood. So that's one issue there. The other issue is that urine is, so the blood ketone concentration will reflect the ketone that's in your blood at the moment when it's tested, right? And that's really what's giving the symptom. The urine measurement is always displaced in time, so that there's always a time lag there, because the urine needs time to accumulate, right, before you eliminate it. And so that will be a reflection of one, your past ketone levels, and it will also be more of an average ketone level that has accumulated over time, depending on how much urine volume you have. So it's not as good for a real-time assessment of your ketone status and what you need right now versus what you needed a while ago. So having the blood ketone available provides more real-time result and a more real-time reflection of what's actually happening with the patient when the provider is seeing them.
Great. And on a related question to diabetic ketoacidosis, it was noted that the KARMA-2 study uses 3.0 millimolars for blood ketone for the cutoff for diabetic ketoacidosis. And the question is there a universal standard or universal cutoff or accepted cutoff for blood ketone levels in diagnosing diabetic ketoacidosis?
Yeah, I'm not aware of one being standardized. And that one they used to determine that someone was having a DKA. And so that's I think already kind of a local decision. But then also what ketone concentration they will consider elevated enough to start the IV hydration. That's also not something that's standardized across the board. So there's subjectivity in that still.
Okay, another question we have here is regarding lactate levels comparing stat strip to the blood gas analyzer. And in the earlier comparison, or the first comparison, you have a negative bias of stat strip when compared to the blood gas analyzer. But in the second comparison you made, there was, and that was especially in samples over 6 millimolar, was that bias was seen. In the second comparison, you have a comparison where there's not as much bias, even over 4 millimolar, and the difference was 9.1%, for example. I wonder if you could comment on that.
The first comparison was arterial to arterial, stat strip versus onboard blood gas analyzer. And so there they were really looking at just the methodology difference between stat strip and the onboard blood gas analyzer. That's why the sample type was kept the same. And then for the second, the little chart that was looking at capillary on the stat strip versus arterial on the onboard blood gas analyzer. So it was comparing both the method against method and then capillary against arterial. But the other thing there was that the 9.1%, that was it was not the absolute difference between results. It was that if you take one sample and you measure it on the stat strip, so if you measure a capillary sample on the stat strip and you measure an arterial sample on the onboard blood gas analyzer for the same patient, in how many patients will the two results both say that the result is less than 2 or greater than 4? So in 9, so out of 100 patients, for 9 patients, the stat strip using capillary would give you a different result than the onboard blood gas analyzer with an arterial sample.
Right. So I think one would have expected a larger bias, greater than 4 millimolar, in that situation, even in capillary versus the arterial comparison, not just the 9%.
I think it's an interplay between the sample type and a little bit the bias between the two devices, right? And so you have to do that's why I think you have to do local validation each time. So for them and the way that the systems they had, for them, arterial and venous samples with those two systems would work well. But in another place, it might be that if it's a stat strip against something else, the arterial-venous combination may not look that great and capillary might look better because there's a little bit of the sample type.
So it's also known that with lactate meters, when doing a finger prick, in especially in sports settings, that often the results can be skewed by lactate, say on the skin or and sweat, and so there needs to be a wipes done before, so pre-analytical assurances that need to be done before the testing. Do you know if that was done here? It looks like there's 2 measurements, so can you comment on that?
Yes, so they specifically commented on this, and they noted that the skin area where they did the puncture was first cleaned thoroughly with 2 alcohol wipes and then afterwards dried with sterile gauze. And they did it to remove all cutaneous contaminations, in particular drops of sweat, which contain lactate and could falsely increase the finger stick, the capillary result. So they did that for each patient before they did the finger stick and sampled the blood. And then they also used a second drop of blood.
Thank you to Dr. Fuzieri and Dr. Banga for that great Q&A session. As we're now getting close to the end of our webinar, I'll remind you to please join us again and invite your colleagues to attend the next Nova Biomedical educational webinar. You can register at novabiomedical.com/webinars, where you'll also find a full catalog of on-demand webinar offerings. For Dr. Fuzieri and Dr. Banga, thank you for your interest and attention, and enjoy the rest of your day.